Hello, everyone. I'm Tony Buffington. And I want to start by thanking the Interstitial Cystitis Association for giving me the chance to talk with you today about what I think is really a paradigm shift, a change in our thinking about chronic pain and what that might mean for us in the IC community. So let me share my screen and we will get started. Okay. So I'm at UC Davis and there's the title of my presentation. You can see that. So let's get started. And my plan is to give you a short introduction, talk a little bit about what we know about interstitial cystitis or think we know, and then about what's new. And after that, I'll talk about what I think it might mean for us and then try to summarize. So who am I? I'm a veterinary clinical scientist. And before I forget, this is my wife, Terry. We just celebrated our 50th wedding anniversary. And so she has been putting up with my obsession with IC for a very long time. I started studying lower urinary tract signs in cats 4 decades ago when I was a graduate student at UC Davis. And about 10 years after that, I learned about interstitial cystitis. And so I've been part of the IC family since the early 1990s. In addition to studies in cats, I've also done studies in people with interstitial cystitis, fibromyalgia, and irritable bowel syndrome. And other than my prejudices and biases, I have no conflicts to disclose. It's an important disclaimer here, and I should read this. One of the reasons I think it's important to have a disclaimer like this is that research on chronic pain has started coming out so fast that I can't keep up with it, and I'm retired from practice. All I have to do is keep up with the literature. So there's certainly things that I don't know, despite my best efforts to keep up, but I'm going to do my best. So here's some things we know about interstitial cystitis, and you can read through this quickly, but what we really don't know is what causes it. If there's one cause, if there's multiple causes, there's been a lot of work on what's called phenotyping or figuring out what's different from among different people, but we don't know if that's related to different diseases or different manifestations of the same disease. And only time will really tell. We also know that there's a lot of treatments, but none of them work very well. And there's an old adage in medicine that says that the number of treatments is inversely proportional to our understanding of the disease. And what that means is that the more you know about the disease, the fewer treatments there are because you find out what the right ones are. And while none of these treatments work reliably in people, we do have an effective therapy in cats, and I will try to talk about that just a little bit as we go along. So one of the ways that pain is described in IC is how bad it hurts and how much it interferes with your life, or what's called pain and bother. And in IC, there's a scale for that, and it's called the interstitial cystitis, or IC symptom and problem index. And you can see it up here. And I'll go through this with you and read it. And if you got a pencil and a piece of paper, you can write down and just get an idea of what your score is. And so for symptoms, in the past month, how often have you had? And then there's these 1, 2, 3, 4 things, and you can score 0 if never, 5 if it's all the time. So a strong need to urinate without warning, urinating within 2 hours, again after urinating, getting up at night to urinate, or feeling bladder pain and burning. So you give yourself a score for each one of those. And then here's how much it bothers you. And you'll notice that the scale's a little different. So none is never, and 4 is it bothers me all the time, a lot. And so we have the same things. We have frequent urination during the day, getting up at night to urinate, needing to urinate with a little warning, or burning, pain, discomfort, or pressure in your bladder. How big a problem for that is that for you? Sorry. And anyway, here's the range of scores. So there's 20 here and 16. So the total possible score is 36. But if you get 0 to 3, and you can see what it is here, 4 to 6, and if you're greater than 12, that's a severe case. Don't worry about it for now, what it is. It's just that I wanted you to have an idea of where you might fit on the next slide, which is a scale of difference in IC severity in primary care versus the MAP, which is the multidisciplinary study of chronic pain in IC that the NIH has been running for a long time. And if you see that in this graph down here, you can see that the colors correspond to the severity. So we got negligible for green, yellow is mild, moderate is orange, and red is severe. And in multiple studies in primary urology practice, we see that the vast majority, more than 90%, have negligible, mild, or moderate disease. Whereas in the MAP study, almost everybody has severe disease. The average of MAP was, I think it's something like 18. The average in primary urology studies is something like 4. And we also know that these severities can change. So whatever your score is doesn't mean that it's fixed. And one way of looking at it is that the more safety and support you have, the better symptoms are, whereas the more threatening one's environment is, or the more sensitive the individual is to their surroundings, the more severe it can become. And we've studied this in clinical studies and also laboratory studies in cats, and also in people I know that have IC. One case in particular that I thought was dramatic was a woman who had fairly severe IC and had minimal signs for a couple of decades. And then her husband got sick and went into the hospital at Ohio State, and it was a very good hospital, and they couldn't figure out what was wrong with him. And within a week, the woman had full-blown symptoms back. So it just shows how things in the environment can affect us and our symptoms. So what about long-term change? Well, again, here's a couple of studies in primary practice. You see the age here, follow-up of 17 years and 6 years. The majority improved more than 50%. In this study, 80% got moderate and notable improvement. I talked to a number of urologists, and there's even some studies on this that show that just getting an accurate diagnosis can improve one's quality of life and decrease their symptoms by as much as 50%. And even in the MAP study, where they were looking at severe patients, something like a third of them improved in their pain and urinary symptoms. So I'm hoping that what the MAP is doing right now is trying to figure out what the difference is between people in this group and people in this group, and how we can move more people from here over to here. So that's just a quick summary of what's going on. And now I want to talk a little bit about some new events. And I don't know if you're familiar with the expression of paradigm shift, but it means a complete change in our understanding. And that's what I think is going on. And by new, I mean that this started in 2020. So your doctor has probably not even heard about it. Nobody's learned about it. That learned about it in medical school is out of medical school. So this is something that we're trying to bring to patients, so the IC community can start working on it together. So there's a new classification of chronic pain. First time in more than 20 years. The last one was before 2000. And so it's called chronic primary pain, or nociplastic in some descriptions. And it's chronic, so it's more than 3 months, and it includes emotional distress that interferes with your daily life and your social world, your social networks, and is not explained by another diagnosis. So that's the definition. And so let me show you in a picture what the different classifications of pain are. First, and the one everybody's heard about and everybody knows about, is nociceptive, which means when you break your leg, it's going to really hurt. And if there's a bone sticking out, there's going to be lots of tissue damage. And if that's not fixed, it's going to become chronic. But because it's something that we can all see and understand, that's how people tend to think pain is. They tend to think it's in that broken bone that's sticking out of your leg. Yeah, button. Then there's neuropathic pain, which means nerve injury. And the best way to think about it from pelvic pain is if you've ever been at a horse farm or been out to look at a horse and you're walking along the top rail of a fence and you fall and one leg goes on one side of the top rail and one leg goes on the other side, and your perineum, or the piece between your legs, hits that wood, you are going to injure the nerves in your pelvic organs. So that's neuropathic pain. And if that's not fixed, and urologists are genius at that, that's going to become a chronic neuropathic pain. The new one that we're going to talk about is chronic primary pain. And that's the one that's coming directly from the brain. And really, all this is doing is reminding everybody that pain is a drive state from the brain. We get input from lots of other places, but the brain decides what to do about it. And then there's also mix. So you can have chronic nociceptive pain or neuropathic pain, but if it starts affecting your life and your social world, then you could have primary pain added on top of it, which is mixed, although that's not a formal classification yet. Some examples of chronic primary pain, of course, we're talking about interstitial cystitis, but other visceral ones include these here, as well as migraine. And then also in the musculoskeletal system, we have all of these diagnoses that are now classified as chronic primary pain. So forever, we thought, well, if we feel the pain in the bladder, what's wrong must be in the bladder. And of course, there's lots of nerves that connect the bladder to the brain. But there's also lots of things that can happen in the brain that are affecting the bladder, because all of this is connected right there in the brain stem. And so over here, we've got safety, social support, and over here, we've got danger. And so in evolutionary time, danger was a predator. And you didn't have to have them bite you to know that you better be running away if you wanted to survive. And we spent millions of years in little small tribes. And if we were excluded from that tribe, we lost all of our protection from the tribe. And one of the things that being in those tribes led to is that we are an ultra-social species. It's kind of funny that I spent most of my time working on cats, and cats are not an ultra-social species, I'm here to tell you, but we are. We need other people, and when we lose that connection, that social pain can hurt, and it's been shown that it hurts via the same pathways as physical pain. So with that sort of quick overview, and I've provided notes, and so you can see the slides in that, and also provided references and some resources. Let's talk about some questions that were submitted. And so first we're going to talk about what causes IC. There's a couple of those questions. And then obviously what most people want to know is, what can I do about it? And just to point out here, the reason I love this picture, because it says here, down here, that if you can read it, it says Pandora opens the box. So here we go. So first of all, do you see any patterns or any patterns in the onset of IC seen? And this is a long, busy quote that I'm not going to read to you by Lowell Parsons, who is a famous urologist at UC San Diego, and says he has seen 9,000 IC patients. So I accept that he knows what he's talking about. And he says the first system is usually an increase in frequency, that the patient doesn't do anything about it until the symptoms bother them. And then the onset of pain is what drives the patient to seek medical care. Excuse me. And, but this can take a while to resolve. That's usually diagnosed as a urinary tract infection. And when flares are multiple or in a short time period or last for weeks or months, they're referred to urology. So we're often way down the track before urologists ever see these patients. And one of the goals is to get these patients diagnosed just as quickly as possible, because the longer they've been affected by the disease, the more likely they are to be suffering from it. And we'll see that. So the other question, what are some medicines for severe neuropathic IC pain that actually work long-term? Well, most IC pain is not neuropathic, it's primary, But there was a long recent review of 65 treatments in 31 categories. So there are lots of treatments that are available for IC. And what they found is that none of them work very well. All of them work sometimes in some people, but none of them reliably work in everybody for IC. So it just means we've got a lot of work to do. That's a reference there. So what I think is a really important question is, what can I do during a severe IC crisis to decrease pain and the flare-up itself? And again, this is in the notes, and this is just one example. There's other resources in the notes, but the Oregon Health Authority Pain Education Toolkit offers 8 modules, and here they are. There's understanding pain, sleep, nutrition, activity, mood, social, how to deal with flare-ups, which we're going to talk more about, and then also about medications. But now we know from the Cochrane review that there's not much to say about medications because they don't reliably work. So I have a nutrition background, so I tend to look at things from a nutrition perspective. So I look at things as, well, first I'm going to provide my client with a menu, and then I'm going to cook up a recipe. So we can look at these 8 modules as a menu. And my recommendation is that you look at all of them. You can go online. There's a couple of page handout. I'll show you one of them in a minute. And you can read the short handout of each module, and then and then decide which one of these modules sounds like it makes most sense to you at this moment. And then go to that module and watch and read all of it. I'll explain that to you in a minute. And if you like it. Try one thing at a time. And if you don't like it, try another model. And then just rinse and repeat on your way through. And the reason I have this rinse and repeat is because you're learning how to brush your teeth here. This is not a one and done treatment. This is things that one has to incorporate into their daily life, just like brushing their teeth or a shower, because it doesn't work if you only do it once. So here's what's in the how to manage pain flare-ups. Sorry. First of all, there's a 15-minute video that discusses what it is and how to create a flare-up kit. There's also a handout that I'll show you a picture of, and then there's some additional resources that you can look at. And so this is, again, all part of the menu. Where would you like to start? What makes sense to you? And it might depend on how, if you're feeling really good, you might want to dig into this a lot. If you're feeling really bad, you just might want to find a way to distract yourself. And so here's the handout. And so these are the kinds of things that you can take a look at in here. And excuse me. One thing I want to make a point about, it says take notes during flare-up. I think what's just, or maybe even more important, is take notes when you're not having a flare-up. So why are you feeling better? And these during flare-up, so in both cases, what you want to do is notice how you feel, and then notice where you are, who you're around, what's your environment. Are the things in your environment that you want to have more in your life, or are the things in your environment that you want to have less in your life if they're making you feel bad? And then you probably had a chance to read this already. And then this is the resources. So that we're not going to go through these in detail, but they're just for this one module. There are websites that you can look at. There's videos that you can watch, and there's books that you can look at. And I've also got more resources in the notes, but you can decide for yourself which one speaks more to you. And some people learn better from websites or videos, and some people learn more from books. So this is all just a menu for you to choose what you want to cook up. And if you have some education, you'll know that it was called a SMART plan: specific, measurable, attainable, whatever all the other. And I think it should be called a smarter plan. And the R on the end should be rewarded. I sort of look at IC at one level as people that have they're like athletes. We're like athletes that have overtrained and have just burned out. And it takes time and patience and self-compassion to come back from a situation like that. And it also takes your social network to get back. And so you've got the support of friends who love you and care about you. Now, just a little bit on looking at research if you want to do it. And so this is research I know about because it was done in cats. This is a prospective, which means we decided what we were going to do ahead of time. Double blinded, so neither the clients nor the clinicians knew what the cat was getting. And placebo, so there was no drug in one of the treatments of 100 cats with IC, about 25 cats per group. And here's what you see is that just like in people, their severity dropped pretty dramatically. In these cats, it dropped about 75% and then stayed that way for the rest of the time. Notice though that the big black line is just the vehicle that the drug was in. It wasn't the drug itself. And the drug here was Elmeron. And the sponsors of the research were so interested in this results that they embargoed the results for 7 years. And so the full results have never been published, but that's what we found. We also found that glomerulations, we scoped the cats before and after, those also got better. And we made a mistake because what you really want to do, and this was done in 1998 and 99, so it was a long time ago. But currently what you would have to do is you'd have to have a usual care or a no treatment group, because the assumption is that this is what happens to the usual care. But if you don't collect the data, you don't know. Most studies of IC, the patients are excuse me, have fairly severe signs or symptoms. And so that's the general assumption. But what you can see here is that it's not that neither of these worked, it's that they both worked. And they both worked really well. It's just that you didn't need the drug. It was just the interaction. And the way this was done is that the owner, a couple of times a day, would call the cat over to, here, kitty, kitty, pat it on the head, tell it was a nice kitty, and give it a really tasty treat with the drug on it. And it tasted, and the cat liked it. And so what we think, and we didn't know enough about it at the time to rigorously test it, then was that the cat stopped seeing the owner as a threat and started seeing them as an object of safety and compassion. But anytime you're looking at research about IC, it has to be this kind of a design, or you can't interpret it. If it doesn't have really good placebo controls in a usual care group, it's only hypothesis generating, not hypothesis testing. And that's what was found in that analysis where I showed you none of the drugs work very well, is that most of the studies were small and not very well designed. Anyway, let's move on a little bit. Someone asked why I can't get DMSO in stills anymore. Well, here's a perfect example that you can't do a prospective double-blind trial of DMSO because it has such a distinctive smell and taste. And oh, by the way, intrabladder installations require a lot of faith and trust in the clinician. And in the last 20 or 30 years, we've learned a lot more about other ways of making the patient feel safe, raising their expectation of a positive outcome, which is about 50% in IC patients. So there's a lot of hope and drive for healing already. We just need to build on that using trauma-informed care and trust. Someone asked about virtual reality. Sure. There's a study, you can look it up if you want. It can be an enjoyable alternative, but not everyone liked it. And so here's an example of if it doesn't work for you, it doesn't work for you. And then someone asked about palmitoyl ethanolamide, PEA, and as far and like I said, I'm a nutritionist, and I think those studies absolutely have to be very well controlled, or you can't interpret them. But I couldn't find any randomized controlled trials of this compound for IC. So that's something we're going to have to wait on results. And then someone asked, what can be done naturally to relieve pain from IC? And what I would say is that all the things that we think about rest, gentle activity, healthy foods, and a positive social life are all the most natural things in the world for treating IC. And then here's one on any new ideas on how we can minimize pain receptors. And as I said previously, we don't have pain receptors. We have damage detectors and danger detectors, but pain isn't something we receive. It's something that the brain decides depending on all the information it gets in. And so, for example, if you're crossing the street and trip and fall and twist your ankle, it's going to really hurt a lot. Unless there's a bus coming, and then you're not going to feel a thing. You're going to get up and jump out of the way of that bus. So it's a decision the brain makes, not just the input from receptors. That's all just electrical activity, like the cable coming in the back of your TV. And then lastly, this person wants to know what they can do about the pain. She's had the disease for 13 years, had a neurotransmitter put in, and that didn't work out very well. They had to redo the surgery, and now she's in constant pain. It flares all the time. She can't sleep, now needs neck surgery, has a herniated disc, is afraid of losing health insurance, hasn't had a penny from the work accident, denied disability, can't walk, can't bend, can't work, permanently disabled. This is the tragedy that can happen when these cases aren't caught soon enough. This woman needs a comprehensive pain management name. She needs at least 2 surgeons to take care of her. She's going to need mental health care for all the worry and depression and fear and anxiety that she's undergoing. And she's going to need a social worker, at least one social worker, to help her figure out all these things about health insurance and disability. That's not something you can expect one doctor to do. She also needs all the support she can get from her friends, because she's only 53 and pain has taken her life away from her. So hopefully, here we go. I think that classifying IC as a chronic primary pain syndrome is going to move people away from those kinds of treatments that don't work very well. And it's going to move them towards things we know that works. One thing that we know works is pain science education. That's actually what I'm doing right now. We've also found that I also think that there will be a much greater focus on social factors, because that hasn't even really been looked at. The biological factors have been looked at, the psychological factors have been looked at, but we haven't really looked at social factors. And to really learn about this, we've got to get patients more involved in their care and in IC research. We need to move the diagnosis into primary care, and that's been done. There's a Project ECHO, which is experts teaching primary care clinicians how to handle these cases much sooner so we can avoid increasing severity. And I think that all of us in the IC community need to work together as our own social network to make these things happen, because I think it's going to be better for patients and their social networks. It's going to improve things for healthcare givers, because they're going to be able to see themselves succeed rather than the frustration of failure. And it's going to be better for society, because it's going to cost us. Chronic pain is a multi-billion-dollar problem in healthcare these days. So anyway, thank you very much. I've probably gone over just a little bit, but I again just want to thank the ICA so much for letting me put this together and talk to you about it today. Stop that, and thank you.